Thank you so much. I'm Tina Master. I am a professor of pediatrics at the University of Pennsylvania Perelman School of Medicine and the co-director of our Minds Matter concussion program here at the Children's Hospital of Philadelphia. And it's such an honor and a privilege for me to be here with you today and to present to you the Amsterdam Systematic Review on Targeted Interventions and Rehabilitation. I don't have any conflicts of interest to disclose. And so just to set the context, as you all know, a great amount of effort and work had been put into the Concussion and Sport Group report that was published last year with the consensus statement, as well as 10 systematic reviews and multiple tools as well. And during this few minutes, we'll cover targeted interventions and rehabilitation. And this is the context in which it is, that the targeted interventions was one of the systematic reviews led by Dr. Catherine Schneider. And one of the R's that was reviewed in this, of the 13 R's, was rehabilitation. And so that will be the main focus of what we'll be talking about today, but we'll cover some other interventions and treatments that were also examined in the systematic review. And just to highlight again, as has been discussed previously, this cycle with the pediatric data, instead of having a separate pediatric systematic review, there were pediatric experts on every systematic review. And this was a summary, actually, of the pediatric data that you can refer to if you're interested in a quick reference for all the pediatric information that was covered in the systematic reviews in the last cycle. And so in terms of this systematic review on targeted interventions, the inclusion criteria are here for you to review. And in particular, really interesting to note that there were over 11,000 records that were originally identified, but then using pretty strict criteria requiring the research to be original research, English language peer-reviewed. This covered a huge time span from 2001 to 22. And in particular, also had to include greater than 50% sport-related concussion, and then had to evaluate the effect of a treatment, an intervention, and then outcomes related to that intervention. And you can see that all listed here. And the flow chart is for your review there. Of interest, after all of the exclusion criteria and inclusion criteria were applied, only 13 studies qualified for this systematic review, and only 9 were really of acceptable or high quality. And you'll see here in this nice figure the categories in which these studies fell into and the age range that they examined. And what's really nice about this figure was it really covered the entire time span after injury, where the intervention was made and how long the participants were followed for, and the time points for the assessments during that follow-up. And so you'll see here we're going to cover topics including collaborative care, vestibular rehab, cervicovestibular rehab, active rehab, and then supplement enzogenol. And so to dive right in terms of active rehabilitation, in terms of this, there were 2 randomized controlled trials that were examined. And in these 2 trials, the active rehabilitation was essentially exercise, symptom-limited exercise that was often combined with some sports-specific training, visualization and imagery, also education in a home exercise program. In this first study, they examined 49 adolescents, children and adolescents, and they were greater than 4 weeks from injury. In both arms, what they found was that there was a similar decrease in concussion symptoms, but in the intervention arm, there was an improved quality of life and less anger on the reported scale. There wasn't any effect observed in balance and coordination, and that's of interest for us to file away for later, in that it wasn't really addressed in this particular intervention. And then in the second study, what you see here is that it's also similar in its use of subsymptom aerobic training, a little bit of coordination intervention related to sport-specific drills, and then also visualization imagery in a home exercise program. And they found that this was safe, and there was a greater decrease in symptoms, concussion symptoms, in the intervention group. And you can see in these two RCTs, the active rehab was an active management with aerobic, subsymptom aerobic exercise, and really in the chronic phase, longer than 4 weeks from injury. And basically, they found that this was a safe intervention, no adverse events, and had some impact, it appeared, on some quality of life and symptoms in terms of concussion. Then moving on to vestibular rehabilitation, there was one randomized controlled trial, and this comes to us from our colleagues in Pittsburgh. And what they did in this trial was examine essentially the effect of an individualized vestibular rehab intervention. And they compared this to more standard care that include behavioral management, so advice regarding physical activity, sleep, hydration, nutrition, stress management, and then they were encouraged to do stretching and some light physical activity, but nothing that was vestibular rehabilitation in nature. And so again, in this intervention, what they found was that there was improvement in a physical exam outcome of the horizontal and vertical VOR, but not vestibular motion sensitivity in the intervention group. But here they're examining an actual physical exam outcome and not just symptoms. Both arms seem to have improvement in dizziness as measured by the dizziness handicap inventory, and the overall recovery did appear to be improved in those who were in the intervention arm with the vestibular rehabilitation. And so you can see in this particular intervention, it's a little bit sooner. So these were participants that were enrolled within 21 days after their injury, and also were primarily adolescents in this study. And then with regard to the combination of cervical and vestibular rehabilitation, there were two RCTs that were reviewed, both again in the small range in terms of N, and again, including teenagers, but also adults in these two. And so these are a little bit wider age range in terms of those who were studied. And they all were included if they had dizziness. And in particular, also, these two studies were a little bit more acute in time frame. The first one in particular was at 10 days after injury, so much more acute than some of the previous studies that we looked at. And so they examined the intervention of cervico-vestibular physical therapy twice a week, up to 8 total visits. And again, they compared this to experience with PT that was either sham or subtherapeutic and really focused on some isometric or range of motion exercises. And there really wasn't any progression in terms of the sham physical therapy that was provided. In the first study by Renneker, what they found was that the symptomatic recovery was shorter in those who were in the intervention arm with the cervico-vestibular physical therapy. And the medical clearance was also as well. In the second study, what they found, this was in an intervention group that actually was a little bit further out, greater than 10 days post-injury, and their inclusion criteria included headache, as well as dizziness and neck pain, and had a similar intervention that included up to 8 weeks of formal physical therapy, and they compared this again to a rest followed by gradual exertion, range of motion with postural and stretching kinds of exercises. And what they found here also was that the individuals that were in the intervention group were more likely to be medically cleared within 8 weeks compared to those who were not. And so again, you can see here in this graphic from the second study that Dr. Schneider led, there was an impressive difference in between arms. Collaborative care is another area of interest that folks have been studying over the last number of years. And in particular, this is from the group out at University of Washington in Seattle, led by Dr. McCarty. And this was actually one RCT, although it was counted as two because there was a shorter term report as well as a longer term report on the outcomes here. And the intervention here really was a multimodal collaborative care intervention that included cognitive behavioral therapy, and then, if needed, actual evaluation for psychology and psychopharmacology if required. And in this initial report out, about a third of the individuals in the study actually did receive that consultation and went on medication. And what they found was that those with high post-concussive symptoms, there was a smaller proportion in the intervention arm than those who were in the control arm. And from that perspective, they also found that there was a greater reduction in depression symptoms in the intervention arm with this collaborative care. But there really wasn't a change in anxiety symptoms in comparing these two arms. And in the longer term follow-up of this trial, what they found was that there were interesting enduring effects in terms of improved symptoms on the HBI at 3 and 12 months, and then PEDS quality of life at 12 months, and also an impact on sleep at each of the interval time points. But overall, though, in the longer time frame, no difference in depression and anxiety symptoms. And so interesting results here in terms of thinking about collaborative care and the approach that included a psychological approach and a psychiatric approach with medication as needed. And then last group here that we'll talk about is pharmacotherapy, supplements, and other, kind of the big, garbage can to catch all in terms of all the other studies that were examined that weren't necessarily rehabilitation per se, but were of interest and worth noting. And so RCT of enzogenol really did not find any difference in recovery. The RCT of magnesium, which was added on to acetaminophen and ondansetron as the control, and this was acutely in an ER setting, showed an improvement in symptoms, but this was assessed to be a high risk of bias study. And so again, hard to take anything home from that study in and of itself as a standalone. The study on amantadine was a quasi-experimental retrospective case control, and they also found a greater decrease in symptoms, but the cohorts were not really well matched in this study, and so there may be bias there as well. In a study that came out of Boston led by Dr. Brown, there were those who were in a higher cognitive activity quartile seemed to have longer duration symptoms. And then in a study out of Akron with Dr. Kunjani, a head and neck cooling device was examined, and there appeared to be a faster decrease in symptoms in this pilot trial. The treatment with the cooling was applied acutely within 0 to 8 days, and then again 72 hours later. And then the last RCT that was examined was one on osteopathic manipulation. And there was only one session after the assessment. And this was compared to concussion education, and there was a decrease in symptoms. But also, this study was assessed to be a high risk of bias. And so I think the future considerations are that we really are looking for objective endpoints for these interventions for the future, potentially more patient-reported outcome measures, operationalized definitions of recovery. Questions that remain include, is targeted treatment better than one size fits all, in particular targeting vestibular versus everything all at once? And then optimal timing, should it be early? Should it be later? Should it be subacute? There's a lack of research in para-athletes, children less than 2, especially less than 10. And what about the influence of gender and social determinants of health? What about the subcomponents of treatment, and what can we learn from non-sport related concussion research? And so this is something that obviously our field is interested in, because in terms of surveying those who attended the Amsterdam conference, rehabilitation ranked number 3 in the future directions for CISG. So I think we'll probably be looking forward to hearing a lot more about this in the future. Take home is light aerobic activity could start as soon as 2 days after injury. Cervicovestibular rehab is recommended for anyone with dizziness, neck pain, or headaches at greater than 10 days, and it decreases time to return to sport. Adolescents with dizziness greater than 5 days may also benefit. Active rehab and collaborative care with persisting symptoms may be very helpful, and there still are many questions that remain unanswered. Thank you so much, and we're looking forward to having questions later and more conversation on this topic.